broadcast is now starting. All attendees are in listen-only mode.
Hi everyone, I'm John from HDN and welcome to this webinar today focusing on digital primary care. So we have a fantastic panel joining us. I'm pleased to welcome Nikki Melinda, the Director of Primary Care at Surrey Heartlands ICS, Dr. Paul Wright, a GP at the Northumberland Group Practice and Deputy Clinical Director and IT Clinical Lead at Manchester Locality and CCIO at Manchester and Trafford Local Care Organisation. Jamie Innes, the Product Director in Healthcare, and Dr. Osman Bhatti, a GP in East London and Chief Clinical Information Officer at North East London ICB. So thank you to the panel for joining us today. So over the next 55 minutes, we're set to cover quite a few topics in terms of digital primary care. And that will be topics such as patients coming into primary care around access and demand, through to digital for care at home, the role of digital in managing long-term conditions, and we'll cover the aspect of the workforce and developing digital skills. And we'll hear from each of the panelists in terms of their projects and programs that they've been working on. And then we'll ask the question, what does good look like in digital primary care? So we've got a lot to go through, really. If you do have any questions yourself, please type them into the chat and they'll come through directly to me and I'll ask them either as we go or we've got a planned Q&A towards the end of the session. This session will be recorded so you can watch it back at a later date and share it with your colleagues too. So I think a good place to start is some introductions, please, in terms of the panelists' role and remit and a bit about your organisation as well, please. So Nikki, could we start with you if that's okay, please?
Yeah, sure, thanks, John. Hi everyone, I'm Nikki Melinda. I am the Director of Primary Care and I work in Surrey Heartlands ICS, which is home of Dr. Claire Fuller, who is famed for their Fuller stock take, but don't hold that against me, obviously. So I cover I've got quite a broad portfolio in Surrey actually. So I not only do the commissioning part of general practice, I also do development of general practice. All the teams for GPIT Digital First Primary Care report to me, so I cover those portfolios. And recently we've taken on pharmacy, optometry and dentistry. We've got about 1.1 million population, 104 practices and 25 PCNs that I work to.
Wow, right, quite a lot. Osman, can we go to you next, please?
Hi, yeah, thanks. Welcome everyone. My name's Osman Bhatti. I'm a GP in North East London and the CCIO, the Chief Clinical Information Officer for North East London ICB. And North East London ICB is one of the 5 ICBs in London, and our ICB covers about 2.3 million patients across 268 practices. And one of the key things that we're certainly been looking at has been, as we come to the end of the Digital First 5-year programme and coming into the Fuller report and the primary care recovery, is how do we actually now move on to making primary care digital to continue the good work that we've done, and also looking at the possibilities of what we can do going forward, particularly taking advantage of utilising the ICB as an ICB now as a organisation in itself to really take advantage of working more closely with our colleagues within other trusts.
Great, thank you, Osman. And Paul, over to you, please.
There's nothing like having some IT problems as part of an IT presentation. I'm hoping everything's working. My name is Paul Wright. I'm a GP in South Manchester. I'm the Deputy Medical Director and IT Clinical Lead for Manchester Locality, which is part of the Greater Manchester ICB. And I also work for the Manchester and Trafford Local Care Organisation as their CCIO. I feel as though I spend my time sort of working in the interfaces at the moment, so working around the systems and processes that sit between patients, practice, primary care, secondary care. And similar to the roles of Osman and Nikki, my role with the ICB is in that, sort of continuing that work around digital first primary care. And a lot of conversations, actually meetings today around things like advice and guidance, and the primary and secondary care interface seems to be a real hot topic of this week. So it's a really varied portfolio, really exciting at the moment in terms of all the different things that are going on.
Thank you, Paul. And Jamie, over to you, please.
Thanks, John. So hi, everybody. I'm Jamie Innes, the Product Director at Inhealthcare. I work with our customers and partners on developing new digital technologies and with our development team on the roadmap for our digital platform. At Inhealthcare, we work with NHS organisations on developing new digital and remote monitoring technologies that support transformation agendas, and we allow NHS organisations to work in different ways. Over the past decade, we've developed over 100 different clinical pathways with our customers and have had over 3 million patients using our services.
Great, thank you, Jamie. Right, the first topic of discussion, can we talk around patients coming into primary care and the role of digital in terms of accessing and managing demand? And can we hear about some of your projects that you've done or doing, your approach to those, and what's working well in each of your different areas? So Nikki, could we start with you, please, on that one?
Yes. So I guess there are three main projects that I'll quickly talk about. There are many that we could talk about. Managing demand is obviously key because general practice is under such a huge amount of pressure, but at the same time trying to balance that with patient experience of coming into the system. So I guess for us, we've been on the journey for, like every system, for quite some time. The long-term plan set out the move to online. We were about to go live with a massive program of work that would have taken us 2 years just as the pandemic hit the shores like everyone else, and we sort of pushed it in and hoped for the best, basically. So we've just been going through a bit of a process to think about our websites across our 104 practices. They all have the same look. So we've moved to a very sort of NHS look and feel to all of our websites, which we hope will help patients be able to navigate because we look the same as everybody else. Our online tool, we've just been through a procurement process, and that's now embedded within the NHS app. So our patients not only can use it on the web, they can also use it on the app, which is brilliant for our patients. But I think the one that stands out for me, which I didn't really expect it to, was cloud-based telephony. And I absolutely know it's all over the recovery plan. But before the recovery plan came out, we decided as a region, actually, the South East region, supported a shift to cloud-based telephony. So we started our journey probably about 9 months ago, trying to move our practices from very archaic in some places. We've got really antiquated systems, moving them into a bit more of a modern position. And I think cloud-based telephony is a bit of a game changer for us in terms of being able to think about the way demand comes in and where we place it. So we've been through a whole process to move to cloud-based telephony, but our job now is to make sure that they utilise what we've given them, all of the functionality and the richness of that for patients that comes with it. So that's the three projects that we've mainly been working on, and we've got some great stuff coming out of the back of the advanced telephony piece. So one of the examples that I'll quickly give is around, we had the Strep A position late last year. We were able, in certain areas that all have the same, that had the same telephony, we were able to put a front end message on and say, if you're calling about a new respiratory issue, just press 1. And then we had a call system type setup where all patients that were calling on the day, and we were seeing increases tenfold across the system in calls into our GP practices to be able to shift those patients into a different position to get dealt with, to be assessed, the need assessed, and then to be rebooked into some of those appointments. So we're seeing some really lovely things play out with just those three, what I think are quite simple tools for our patients in general practice.
Fantastic, thank you, Nikki. And I'd love to dig into those a bit more, and perhaps we do later on in the call. But how about in North East London, Osman? What are you doing in terms of patient access?
Yes, it's very similar to Nikki. I think we've got several work streams. I think digital first, we had about 14 different work streams that we were looking at, some not as shiny as others. And I suppose we always focus on the shiny stuff that's always in the news, but some of the other things we focused on that really helped with our foundations were things around care homes and social prescribing. And care homes was one of our big achievers. We tried lots of different things with care homes, but one of the biggest things that we needed to do was get the foundations right with the DPST toolkit. So we really worked with all of our care homes, and virtually every single care home now has been through that process and understands what the needs are for their service, to then build on connecting with other systems to access clinical records, for example. So we've done a lot of foundation work there, which I think the team has been absolutely amazing with. Some of the other work that we've done has been around social prescribing. So North East London has got some beacon social prescribing sites, and one of the things we wanted to do is spread the way that we do social prescribing. So we've done a lot of work around, again, trying to get some of the basics right. So how are all of our social prescribers coding and writing, and what are they using to document? And if they are documenting, how can we get them to better code, to better search on what is being done? And outcomes are really tricky sometimes to code. So there's been a lot of work in that. And again, some of the standard work around online consultations. Historically, North East London had one online consultation provider, and that was quite varied. And with consultation with our practices, we soon discovered that one size doesn't fit all. So we opted for an approach where we procured one of 3 options for practices. So practices had the choice of one of 3 different online consultation providers, which has increased the uptake. And then there's the whole facilitation. So we've put a lot of effort and resource behind facilitation work. So it's not just having the tool there, but it's how to use it, how do you consistently maintain it through a PDSA cycle, and getting that QI approach to it. So we've invested quite heavily in facilitators to help support that process and program of work, and again, like Nikki, making sure things are integrated well. So using the NHS app as our one entry point for patients, and also trying to make sure that practices don't feel pressured, because there is lots of pressure on practices, and online consultations, I describe it as opening an extra tap into the overflowing bathtub, and before you do that, you need to make sure that the other taps have been turned down, so that you're not just doing your face-to-face telephone consultations and then introducing online consultations on top. It's how do we reduce those to allow online consultations, so that there's a balance of things coming in. So it's been an interesting journey.
Fantastic. Thank you, Osman. And Jamie, from your perspective, how can digital tools play a role in access and managing demand?
Yeah, so I think it's a really interesting area, and one of the case studies that I'd like to highlight is in the northeast of England, where we worked with Newcastle and Gateshead to introduce a MSK self-referral programme back in October 2018. That programme now has been running for nearly 5 years, and the way that it works is that patients are able to go online, fill out these online forms that are validated against the spine, and then information is triaged, and it avoids unnecessary primary care appointments. You know, approximately there are 1,500 patients that go through that every month, and there's over 50,000 referrals that have been occurred to date, and that really avoids significant activity and takes away some of the need for this activity taking place in primary care. This has then been replicated across other services such as bladder and bowel appointments and phlebotomy, and it's introducing different ways of access for patients that's providing them with other options and avoiding the need for primary care to maybe sometimes be the gatekeepers in terms of some of these services.
Great. Thank you, Jamie. And Paul, how about in Manchester?
I think listening to Osman and Nikki, we've got similar roles, so there's a lot of overlap with the cloud telephony, the NHS app and things like that. I think I'm trying to think of what's different, or one of the things definitely to celebrate, I think, is we have had a quality improvement scheme as part of sort of clinical standard scheme in Manchester for several years, and we use that as a platform to support practices to have some investment around doing QI for digital-based projects and gave them some choice around what they could do. So they had a choice to either do things relating to NHS app, online consult, long-term condition management, or working, with specific patient cohorts. And that was through 22-23. It was really good to kind of bake in that quality improvement approach, and alongside that, there was a quality impact analysis training, so that people were doing, digital projects alongside a quality impact analysis, so that we were looking at the sort of the associated risk of discrimination coming in through sort of digital channels. We've rolled that through to this year into working on the NHS app, the NHS website audit. So the majority of our practices have opted to do a QI project around that. So we've got our 83 practices have all engaged or been supported to engage, submitting information around that, and we'll be using that to speak with system suppliers, and the practices will be encouraged to take action on that to improve accessibility using that website audit tool. So really excited to see how that takes us through the year. And that links with work that came from actually our Health Scrutiny Committee and Health Watch around feedback from patients. And so we're hoping it supports a cycle of sort of work and feedback that's linking the system. So I think that's something quite exciting to be keeping us busy through the course of this year.
Absolutely. Can we move on to talk around using digital tools for managing long-term conditions, and particularly how you might be doing this in your area? If there's one example you can share of perhaps what you did, what worked well, and what the impact was. Paul, can we start with you, please? Is that okay?
Yeah, that's fine. I'm going to go back to the quality improvement scheme, actually, and I'm riding on the sort of coattails of other people's work here, but that's okay, because I'll try and name them as we go. But as part of that, there's clinical standards, and the way that we've delivered that's been a real sort of team effort in terms of we have a data quality team that's part of sort of the NHS GM infrastructure. So we have all on EMIS in Manchester, so we have tools and resources developed to help us support particular activity. So there's been activity over the past couple of years in terms of inclusion and multimorbidity and looking at sort of the recovery post-COVID. And those tools are supported by, guidance support and training to practice, but also we've got a really strong business intelligence infrastructure. So we've been an accredited safe haven for some time, and Matt Conroy, Graham Haler have built over the years a sort of a BI platform that enables us to produce. It's actually down at the moment as we've moved to NHS GM and it's having to be rebuilt, but it meant the practice could have there's some really good informatics around what's happening with their population to understand who the key target groups are, and has supported us as a city to be able to have a really connected sort of approach with regards to specific target areas. So that's, I think, in terms of long-term condition management, that's most probably one of the most substantial things we've done over the last couple of years.
Great.
When I say we, I always make a point of the work being done, and I think Osman lent on it before, but it's not me, it's the practices, it's the practices, the practice managers and all of this stuff. When we say we're doing it, it's very much the work being done by the frontline staff and clinicians.
Absolutely. Thank you, Paul. Nikki, how about in Surrey Heartlands?
So, I mean, there's all the general bits and pieces that I'm sure everybody on this call is doing, thinking about, the at-home model from NHS England. We're using the Inhealth platform to automate changes to patients' positions, and which I think is the most powerful piece that we've got, to be honest with you. I guess for me, there's a bit more about how the impact that we've had to some of those patients. So just using an example, we've got a patient who's been through our BP at home model. And it's really interesting. Their feedback is all about they didn't really realise how much influence and how much they could do for themselves until this point, until they started to measure themselves and start to contribute to their healthcare journey. And I think that's probably a really, significant impact that we've had on a population who really needs the input and the structure into this. So I think what we do in general practice is, and I'm not saying QOF is wrong, I actually like the quality and outcomes framework, but we measure, we kind of see the same people for the same condition for the same amount of time, but actually we need to highlight those who are going through something slightly different or have changed or have moved into a certain sphere. So I think the work that we've done on bringing all the data into one digital platform has been really significant. I think also, and sorry, it's just, I'm going to talk about this a lot, but we've got, and again, what I say exactly the same, it's not just me, I've got a team of people, and the practices in Surrey have been absolutely phenomenal throughout all of the process and all the changes that they've had to make. But we have a programme of work that we call the GP Development Toolkit. And within that toolkit, we start to really think about what I refer to as the inbound and the outbound. So the patient's journey in to the GP, through their healthcare journey, so into the GP practice, but also how we reach out into populations. And I think for long-term conditions, that's really important, because actually some people are really good at giving you the information that you need up front. Some people aren't as good at it, and we need to start remembering that actually patients, we could start to respond to different cohorts of patients in different ways. So I think that's, for me, probably the most significant way that we have impacted or started to impact the populations.
Excellent, thank you. In North East London, Osman.
Yeah, so I suppose just if we reflect back, a lot of the things that we've done haven't been groundbreaking, but they've just been basic things, because I think if you get the basic things right, things just work and fall into place. So one of the things coming together as an ICB was that there's lots of practices in historically different CCGs doing things differently. So how do we standardise that? So we're quite blessed with a good clinical effectiveness group, CEG, in North East London, who helped us to do the basics. So getting the basics would be, how do our practices know what they need to do for long-term conditions, and also actually not just reactive care in long-term conditions, but proactive care? Because I think over the last 2-3 years, I see patients who haven't had a blood pressure or weight done, and it's changed dramatically, and we haven't monitored those that now have long-term conditions historically as well. And what they've really helped us with is to standardise the data going in. So as long as everybody's got the same standardized way of entering all of their data, so we're coding everything well, then we can dashboard correctly, then we can output to practices, and then build protocols and searches and bespoke pathways for practices to say, actually, there's a cohort of diabetics that haven't been reviewed, or some haven't had a blood pressure, or some haven't had a HbA1c, and then stratify that risk. And we've been able to do that quite effectively in a supportive way. And I think all of this should not be with any stick, or to say you're bad because you haven't done it. It's very much, look, we're all struggling. This has worked well for those who are doing well. How can we implement that for those who aren't doing so well? And again, that's coming back to the facilitation. So really pushing that support practices to say that here's a team of people who can essentially come in, support you run the searches, help support in getting your processes in place to help with things like recall, and to really encourage the whole ICB to come up to a standard. And that's been what we've really looked for with long-term conditions, and diabetes is probably the biggest one from North East London, but things like COPD is another big cohort that we really need to be focusing on and are focusing on.
Fantastic, thank you. And Jamie, from your perspective?
Yeah, so I just wanted to build upon one of the areas that Nikki mentioned, actually, in terms of working with Surrey Heartlands on a blood pressure at home programme. This has been a really successful programme, and I think it's being used by approximately 2/3 of Surrey Heartlands currently. To date, I believe there's been over 3,500 patients through the pathway, and initial evidence showed that just over 50% of the patients on the pathway moved from a high to a normal blood pressure within 6 months of being on the programme. And half of that's due to diet and lifestyle changes. As Nikki mentioned, patients suddenly realise actually they can empower themselves and make changes to their own diet and lifestyle that impacts their own long-term conditions. but also, as well as the patient outcomes, there's been significant savings for primary care in terms of time and appointments. And initial sort of pilot feedback across 4 practices was that it saved approximately 80 GP days compared to previous ways of working, which is tremendous once you start to scale up these digital initiatives and make them ICB-wide programs. We're working with National Services Scotland on a similar type of model, and they're looking at replicating a lot of the learnings and the evaluation that's come out of Surrey and developing this into the largest BP programme in Europe with 40,000 concurrent patients on the programme. And that's where scale and economies of scale for digital technologies result in significant improvements and changes across primary care.
Great, thank you, Jamie. And that leads nicely into what are some of the lessons learned in terms of care at home, remote monitoring, and how do you scale that approach and that model? What's your advice is the question. Nikki, could we start with you on that one, please?
Well, I'm a big believer in you have to start somewhere, so you go wherever the energy takes you to go, because all of a sudden people start to follow, But I think there are some important factors for general practice itself. So it is just too busy. It needs the time and the space to think about how to change its pathways and to think differently about things. So without meaning to say the GP development toolkit again, we do have this package that we brought together that starts to think about those 2 main models, so the inbound and the outbound, but also about the efficiencies that practices can bring to their own practices. Now, I think it was Paul that mentioned the NHS app earlier. I think sometimes we underplay some of the things that are standing in front of us, and we don't utilise them to the best position they could be. We don't really engineer the way that people take them and use them. So this whole development programme, we've actually put on 3 half-day training for every practice, and every practice can either say they want to come or not, and all 104 have opted to come in. There is some funding available, but it's to make sure they can protect their time, where we start to show them what the new things and the ways that you can make your pathways a bit more efficient are. But I think, to be honest with you, there's a lot of giving people time, but also giving them the information that is out there. There are thousands of providers out there doing the same thing, and they just need to know who and where to go and how to access the right thing. So I think it's about time and sharing learning. I think what we're trying to do in Surrey is almost get a little bit more of a consistent offering across the practices, because through all of the insight work that we've done with patients, the one thing that they come back to us with consistently is the inconsistency of how they get dealt with as they come into the system. So we're kind of trying to get a more consistent picture across the 104, standardise where we can and where it's right to do so. And then above that, we need to think every time we do something, at what level do we think it's right to deliver this? Do we need to place it into each GP practice? Could we do it on behalf of those practices? Could they do it at PCN level? So I think every product and every change that comes into the system, we all just need to think about the layers and the work, and the position that we place everything.
Great, thank you. And Jamie, coming to you, in terms of lessons learned from any of those projects that you've just spoken about, Scotland, North East, what would you say some of your advice and lesson learned from those?
Yeah, so I think one of the key elements, and Osman actually mentioned it earlier, in terms of one size doesn't fit all, that is a very common theme that we see in terms of digital technologies and especially engaging patients. You need to keep things really simple and easy for patients to use, and a lot of it's about inclusivity and accessibility for patients, providing them with choices and options. A digital approach isn't going to work for all patients, and it needs to have some accommodation to be able to supplement that with other forms of face-to-face approaches. And this is where we use different technologies to be able to engage patients using simple communication methods like text messaging, so that we're not relying on smartphones and people to have internet connectivity to be able to use digital solutions. So having lots of options for patients works really well. One of the other key lessons learned that we've seen working with Scotland as an example is they've worked really hard to create solutions and standardize it across their entire regions and across the national perspective, so that they can standardize it and make it simple and easy for everybody, so that regardless of where they live, which GP practice they access, they all get the same standardized level of care and access to services. And I think that standardization of approaches has worked really well for them. They've brought together clinical leads to develop these digital solutions, trial them out in areas, gather feedback, and then make them national pathways. And if that approach is taken in the ICBs in England, I think it'll work really well, because you end up with consolidation of activities. That's where you benefit really well from digital scale and economies of scale across the entire piece.
Great, thank you, Jamie. And Paul, over to you. What are some of your lessons learned in this area?
I think we're hearing the same things from everyone, really, in terms of, I was just listening to what Jamie was saying, and Osman's touched on it a couple of times. It's about getting the basics right. I think I get a sense, you know, Osman and I will share a passion for sort of clarity with regards to coding, you know, and pathways and flows being sort of very clear and well defined, because I think, you know, getting the basics right, keeping it simple, are the sort of underpinning principles. And I think there's always a good space for a bit of sort of six-hat thinking. You know, what are the barriers? What's the sustainable investment that we're bringing to the local economy with this? What's the problem that we're trying to solve? These are the sorts of things, you know, at the inception, I think are crucial, that are well thought out and answered, because hopefully what we do through a successful, you know, project is then, you know, land something for the future, as Jamie was describing. If we demonstrate that benefit, we're redefining pathways and you know, investing in our infrastructure in a meaningful way. And the risk is, if we go off without that sort of critical thinking at the start, that we don't get that sustained change that we want to achieve.
Great, thank you. And Osman, do you have anything to add to that?
I think just to say similar to everyone else, but I think the main point is, if it's not working, then change something and try something different, or can it? Because I think we don't often, we start things but don't stop things. Like patients' medications, you start them on something but you don't ever stop something else. So it's a similar thing about that. And if it's not working, think why. And we've used a six hats thinking approach. It's a really great tool. A good example is the NHS app. Rolling out the NHS app, we were wondering actually why am I getting traction? Because it should just be, you know, you pick up your smartphone, everything should be intuitive, and that's where, you know, people like Accurex have really dominated the market. But there's things like, actually what we really found was that the staff didn't know about the NHS app, so how could they inform patients? So we just got staff to use it for themselves. So download the NHS app yourself, see how it works, and then they're much easier in their heads to explain to other people how to use it. So it's things like that we just need to stop and think if things aren't moving, and not just keep pushing the agenda. And another analogy, like analogies, but one analogy that I always point out also is the fact that practices are pushing a square-wheeled cart, and I can wave as many round wheels at them, and they know that it'll be better for them, but they can't stop to change the wheel. And we just need to give them support to stop and change the wheel for them to move.
Excellent, thank you. Can we talk about the patient perspective? How, in a healthcare system, PCN, how do you engage patients to use digital tools? How do you activate them more in their care and using digital tools to do that? And if you've got any examples of that from your areas, in terms of how are you doing that, and what's the best way to do that? So Paul, can we come to you to that one, please?
Yeah, I think there's no one right way, is there? I think with all these things, there's multiple routes, multiple approaches. We're really lucky through the Digital First Primary Care Programme to have some excellent digital facilitators as part of our locality team, and they've been supporting projects engaging in local community. And I think that we've recently been working with industry and using some of the volunteer work that they support to actually support PCNs and practices to run sessions to engage people with using the NHS app. And that's lent into other conversations with industry around actually what's the opportunity there in terms of the workforce and promoting NHS app in that space. So I think there's all these different routes, and it's just that continued sort of exploration of opportunity at a practice level, actually that hands-on, making sure the staff know how to do things, then engaging patient participation groups. We've got forums like the Manchester Disability Collaborative, which offer opportunity in terms of patient engagement and patient participation groups. So that COVID-like approach of actually making sure you've got that strong patient engagement and trying to follow the spirit of co-design. So patient engagement through the process from the start is the key in terms of defining new pathways, new processes. So lots of different ways, I think, is the quick answer, John.
Yeah, excellent. In terms of the workforce piece and developing digital skills in the workforce, there's different programs run centrally at the moment, and in terms of funding as well. How have you taken that in your area, say, Osman? What are you doing to develop digital leads in practices and across your ICB?
Yeah, so it's something that we want to try and build, because I think the expert representative is within our teams already, and we've looked at how can we develop clinical leads, and we soon found out actually it doesn't have to be a clinician. You can have a digital leader rather than a clinical digital leader, although clinical digital leaders are also important. And we've looked to get a representative, for example. So what I've done as my role in North East London is ask every PCN to nominate a digital person that can liaise with me, and I can liaise with them just as a conduit back and forth to PCNs. So rather than 268 practices, I'm dealing with 42 PCNs, which is easier to manage. And the representatives aren't funded in any way, but they are just that conduit. So just having a enthusiastic conduit, and it could be the enthusiastic receptionist who leads on digital in the practice and can then disseminate things across the PCN. So it's things like that that we've really focused on, and that's working really well in terms of getting information back and forth. And then on top of that, you've got the official clinical leadership, which again is a challenge, because clinicians were born to be clinicians and not managers in a way. And again, trying to be flexible with that workforce. So setting up Teams channels and places where we can just put things down for us to share and don't have to attend regular meetings. We can just dip in and out of, and we can see that somebody sent a message that we can reply to. So having those kinds of flexible ways of communicating to build that team has massively helped, and also encouraging clinicians to become and non-clinicians to become part of things like the Digital Academy program and going on things like that to really support them in their journey, because it is going to be what a lot of areas will need, and we need to improve the cohort of leadership we have.
Fantastic, thank you. Can we move on to talk about some of the challenges in primary care, both in terms of the challenges in terms of the technology challenge, if there's one, and any sort of discussion points we can talk around that, and if you could solve one challenge, what would it be? So 2 parts to that question. Jamie, can we come to you first, please, on that one? What's the challenge, and what if you could name one, how would you overcome it?
I think as a technology provider, one of the key challenges that we face, and I know it's a long-standing frustration, is integration into some of these primary care systems. Having a single set of standards and integration APIs that would open a lot of doors and allow for new digital innovations to take place would really benefit everybody. I think it would allow for new innovations in primary care and allow for more digital solutions to be taken forward with patients, using the information that's within their records, and also streamlining the process for healthcare professionals, because I'm aware in primary care especially there's still lots of manual activity that takes place where information has to be associated with the record, and it takes up valuable clinical time. So anything that can streamline that process and allow clinicians to spend more time with their patients is a benefit for me. So I know it's been a long-standing issue, and I know there's been lots of initiatives to try and solve it, but I think for me, having a standard set of integration APIs that everybody followed within the industry would make things a lot simpler for everybody involved, not just industry.
Great, thank you, Jamie. And Nikki, from your perspective, in terms of challenges, and if you could solve one, what would it be?
So I don't disagree with anything that Jamie has said. I think that's absolutely right. But as a, you know, when you're working in the ICB or in a practice, I guess one of the things that is quite challenging is the amount of providers in the landscape at which you're looking at. And I think the NHS, the way that the NHS England works, the frameworks that they put forward are helpful, but I think we need to do more to almost make sure we are narrowing the pitch and getting to the right providers before we allow, you know, millions of people to go off and try and do it themselves. So I think that's one of the things that we could do. I think from a provider and a user perspective, I think any provider coming into a system needs to understand that we are moving at a rate of knots. So the pace of change, we can't stand still. I think Osman said it earlier, you have to keep iterating it. It's going to keep changing every single day. We're asking for changes to something to make it more usable and more adaptable for the people that are using it, either side, so the patients and staff. If there was one thing I could solve, I wouldn't be me if I didn't sit here and say I wouldn't mind us sorting out the finances to all of this from an NHS England or an NHS perspective. I think to do all of these things and you know, I think we mentioned earlier, digital first comes to an end in 2024. And that's a really difficult time for ICBs. So we really need to think about how we move into ensure that we continue to progress all the things that we're trying to do.
Excellent, thank you. And Osman, over to you.
Yeah, so it is an interest so similar, really. It is very much looking to try to see, actually, so a lot of it is out of our hands. So the funding coming into primary care needs to increase fundamentally, because that's the need that's required, and the promised 5,000 GPs turning into a negative 2,000 GPs hasn't really helped either. So that's fundamentally what we need to do, and we can throw all the digital tools at the workforce and say use this to improve it, but if there's nobody there to use it, it's not going to work. So it is very much looking at workforce plans and how do we support our practices in that workforce. And again, it's going back to the basics. Let's get the fundamentals right. You know, things like making sure the machines switch on in the morning within 30 seconds and not 30 minutes, and trying to enable the basics, and I think looking more at those foundations.
Fantastic. And Paul?
It's a massive question, John. I'm really struggling here. I love all the answers.
Sorry to come to you.
I think the demand and supply overflowing bathtub analogy is really significant, and as much as we support people to adopt the digital transformation, my concern is the fatigue, transformation fatigue, digital fatigue, and the workload overload. So there's something very sort of, you know, blue sky thinking, which would be actually to recognise that there is a finite amount of work that can be done. That would be great if we could actually agree that and say it's okay to say we're full, or to have an approach to managing that when that's the case, because we're all being told that we need to work towards this, you know, being able to manage everything within 2 weeks. I think that's going to be a real challenge. But from a system-specific perspective, I would love for there to be more integration around actually recognising the capacity of teams within the software, so that actually there was a real recognition of workload management that thought forward, so you weren't having to do complicated things around your rota to try and have pseudo metrics to try and calculate what you can do on the day, and something a little bit more intuitive around the online consult platforms where the system did some of that management for you, something very practical and achievable that people listening to this might go, oh, I could do something with that, and that would be great.
Excellent, thank you. One more question from me and then we'll go to questions from the audience. So if you have any questions, type them into the chat and they'll come directly through to myself and we'll go through that. But the last question from me is, well, two. What's on your plan for the next 12 months? What's the road ahead look like in your area? And also, what does good look like for digital primary care? If you could summarise that too, in the next 2 to 3 years, what does good look like? Nikki, could we come to you, please?
Yeah, thank you. I'd rather have followed someone else on that one, to be honest. So in terms of what's important for us over the next 12 months, the GP development toolkit, rolling that out, giving people the space and the, just showing them what they can do and helping them to get to the right position where we need to, a bit of consistency where we need to, for patients' sake. So the GP development toolkit. And I guess the one thing that I think is really important, and Paul, I think you've just touched on it, is the automation where we can automate. Where we have products that can do it for us, we should be, stripping out some of that demand before it hits the wrong person or the right person or whatever. So yeah, that for us, and in terms of what does good look like, I'm quite a simple person. I just think if we can help general practice to respond to the increasing demand that they have in the most simplistic way, that they don't have to think, too much about that. That's all that's required from me.
Thank you, Nikki. Fantastic. Over to you, Paul. What's on your plans for the next 12 months?
I touched on it before. I think we've sort of talked around the overall sort of digital first program. In GM, there's work ongoing around sort of primary care blueprint, and that's sort of setting the scene for that forward view is going to be key. I think it'd be great to see that we're thinking about the communication, engagement, education as much, if not more, than we're actually thinking about the software specific solutions, because ultimately it's going to be the workforce that do this. And so investing in that is equally, if not more important. And actually that standardization, the communication engagement for the general public, it is crucial. So we've got, I think, as much, if not more, to achieve in the sphere that's outside of the software itself. And so being able to support and build on the amazing digital facilitators we've got, digital champions coming through from practice, I think that's going to be a real key for the next 12 months.
Fantastic. Jamie, over to you.
Yeah, so from a sort of technology provider perspective, over the next 12 months, we're focusing on integration with some of the national systems that are now opening their doors, things like the NHS app, which are now being available for technology providers to leverage and surface their content to patients through that interface. I think in terms of what looks good and what I'd like to see sort of 2 or 3 years from now, I think, regional scale and adoption of digital technology is really key. We've been doing some great work in areas to really scale out programs across an ICB area and then expanding that into new areas. So in the area of cardiology, where we worked with Surrey Heartlands on hypertension, that's now moving into heart failure at home. And it's just great to see how these programs are evolving and taking on new conditions as they start to scale. I think what I'd like to see in the future is some real drivers and focus on prevention and looking at using digital technologies to enable early screening and early assessment and identification of patients at risk. And I think that's more, from my own perspective, about trying to prevent future demand. I think we already know that the system is struggling with the demand that's already being faced on it, and therefore any interventions and early prevention that we can start to bring into the system will help alleviate and reduce that future demand, because we know that it's already going to be a challenge to meet those future demand needs. And recent publications that have demonstrated the increasing number of long-term conditions that are going to be there in the next few years are really going to present an already tremendous challenge to an already struggling system. So I think that's where I'd like to see some more activity.
Great, fantastic. Thank you, Jamie. And Osman, your year ahead, and then what does good look like?
Yeah, so I suppose if I look at the outcomes, we want the patients to be seen by the right person first time. in the right setting, and that provides a lot of challenges for PCNs and ICBs as we work in a bigger footprint. So it's not all about using digital tools. So digital tools are great for taking a cohort of patients to do it in that way, but then you will still need to make sure we've got the right telephony and the right avenues of face-to-face for those people who can't use the technology. So it's about working on those pathways more, and again, coming back to some of the basics around data. So having consistency across the whole patch, not only now from primary care but also from secondary care. So building on how can we now influence as an ICB what happens in secondary care that will have an impact on primary care. So some of that is around workload shifts and how can we use technology to better manage things like referral pathways and consent before operations and things like that. So there's lots of things that we can potentially look at, but it is very much also fundamentally looking at infrastructure, because one of the biggest challenges we're now realizing is that with the increased number of staff in our practices, our network switches can't support so many extra desktop PCs. So it's basically down to that infrastructure of how do we now manage that. So remote working, for example, is a potential solution.
Fantastic, thank you. Right, we'll go to some questions from the audience. We've had quite a few come in. The first one is for you, Osman, around the workforce piece. Given that there are paid digital ARRS roles, have you explored this as a route to increase use of digital technology? Is the question.
So yeah, so it's really interesting. So yeah, so digital ARRS roles are now possible, although the funding for ARRS hasn't increased, and a lot of practices and PCNs have committed the funding. So it's a matter of how do we improve that communication. So a lot of it is about communication. So rather than the ARRS roles, and ARRS roles are very much there for PCNs to utilize, but as a system, let's improve communication. Let's have a linked person. Doesn't have to be the digital ARRS person, but could be. But anybody who's interested can communicate back and forth, and also using our facilitators to help support practices in those digital roles and implementation. So yes, ARRS roles are good if PCNs can budget for them. If they can't, we're still going to try and maintain equality.
Fantastic, thank you. Right, the next question is around population health management tools, and this one's come for you, Nikki. The question is, does it mean that you're using population health management tools to proactively manage the care of patients with long-term conditions? And the second part is, how is that being acted upon at practice level?
So we do have population health management tools. I was specifically talking in the outbound piece, I was talking about reaching out into the long-term condition cohorts, so actually using the quality and outcomes framework within general practice. We have got, when we think about the at scale position, what we're thinking about doing is using population health management tools. We've got GraphNet, for example, to select the cohort, and then especially around the top 1%, so the people who use healthcare the most, and reaching into populations like people who don't have immunisations. We've got quite a lot of that. We're not fantastic at childhood immunisations in Surrey, so it's about finding those people and then using a sort of at-scale care coordination to drive into those populations. But yes, we do use population health tool.
Fantastic. Thank you. We've got time for one more question. It's quite a long one. So from a PCN perspective, is there potential for processes that could be automated? For example, document management, for which AI is likely to play a big role in terms of automated reading, importation, interpretation, coding and action. And what would be your approach or views on this? Who would like to take that question?
I can turn it on its head and say, rather than every practice doing automation themselves, why don't we get consistency in the trusts doing the coding for us, and then that coming down the line? So that's the approach we're taking.
Fantastic. Thank you, Osman. Right. It's 12:58, so I'm going to have to close the session here, but thank you to the panel for joining us and taking the time to share your views. It's been excellent, and I think everyone on the call will share the same views too. We've had a real popular webinar. There's been 170 people watch over the hour, which is fantastic as well. It has been recorded, so you can watch it back and share it with your colleagues at a later date. We have a session starting in 2 minutes, and that will be with Dr. Manal Bakai, the Director of Primary Care Transformation, who will talk around a model of digital general practice. So that's in 2 minutes. I hope you can join us for that. So I'd just like to say thank you to everyone for attending, and again to the panel, appreciate your time and thank you for joining us as well. So thank you everyone.
Thanks everyone. Thanks John.
Thank you.
Thanks a lot. Cheers, bye.